Hello, everybody. Thank you, Skip. Great job. So my name is Dr. Eric Rightmire, and I'm the sports orthopedic surgeon at PBO. So I'm actually board certified in both sports surgery and general orthopedics. I did a sports fellowship out in California in San Francisco. Additional background, I did my residency at Harvard. Before that, I was back home in New York for medical school and a Harvard undergrad. So I guess Skip and I saved our anatomy textbooks from medical school. So we've been over this slide already, just a little bit about the anatomy of the knee. What I'm going to focus on more is the soft tissues, so the ligaments, the ACL, the PCL, the meniscus, in addition to the cartilage. But a lot of what I do is more dealing with the soft tissue aspects of the knee. And then hopefully to avoid this situation, which Dr. Zabilski delved into in some depth, where the knee wears out. So my job is to try to prevent injuries from getting to this point. So I do everything knee, from sports all the way to total joint replacements. And then sports also includes arthroscopy of the shoulder and hip, which are my other specialties. So nonsurgical management is always the first step with injuries in any age group, especially the middle age groups, which we're talking about today. And that includes all the things that Dr. Zabilski talked about, the anti-inflammatories, rest, and all the various injectables, new ones which are always coming onto the market. Physical therapy is one of our greatest assets to restore full range of motion, normal gait, regain muscle control and tone, and build stamina. And the therapists, I'm a big fan. It can always do wonders with the vast majority of these injuries, preventing the need for further invasive procedures. And then complementary medicine is also becoming more popular through older systems like use of biofeedback for pain control, yoga, acupuncture. More and more patients are coming in and talking about these sorts of treatments and how effective they've been, in addition to the topicals and other things that we talked about. So surgical management comes into play if after an injury, there remains persistent instability or pain, despite these conservative measures. And by the time I'm getting to that second or third appointment where symptoms have persisted, or in the case of an acute injury where there's a trauma, surgical management comes to the forefront if there's instability on exam, or if you haven't made it to the point where you need to be to return to your desired activities. Surgical management has advanced considerably since I started practicing 15 years ago, did my fellowship. Newer, less invasive treatments are always coming around. Arthroscopy is considered probably the least invasive of all procedures, given that it's 2 3-millimeter poke holes, or 3, depending on which joint you're dealing with. Smaller incisions for traditional surgeries, hopefully making the operative experience overall a more pleasant thing. So meniscal tears, specific to the talk today, there's 2 different types that basically can be divided into traumatic, which can be either non-displaced or displaced, or degenerative type tears, which are more associated with arthritis and other chronic conditions of the knee. So traumatic meniscal tears tend to occur suddenly from a trauma, usually a twisting type injury, sports related or otherwise, where the femur and the tibia can kind of grind together and catch a piece of the tissue and cause it to tear. In the top row, those 3 examples of meniscal tears are the traumatic or displaced kind. The first one is called a bucket handle, where you get a flap of the tissue that flips over, almost like the handle of a bucket. And then the flap tear, or the parrot beak tear, is the middle one, where you get a little sliver of meniscus. You can see how both of those would be unstable. The fragment can move around and cause what we describe as mechanical symptoms in the knee, where you get swelling, pain, blocking, catching, or other symptoms that cue us off to something that may need surgery sooner than later. And then the third one on that top row is a radial tear. And then the degenerative tears, you see more of a fraying of the meniscus, and more associated with arthritis. So these first two are what they look like through the arthroscopy camera. First one is a bucket handle tear. The one on the lower level is a flap tear. And these two are both unstable, which is why they end up needing surgery to either repair or remove. And then this is what a degenerative tear looks like, where it's a bit more frayed, less structural. Those typically are associated with arthritis. You can see a little bit of arthritis in the upper and lower parts of the joint, in the femur and the tibia, and these would be debrided. So debridement, pretty simple. Go into the knee joint with a shaver or meniscal biter and remove the damaged part of the meniscus. Repairs are constantly evolving. Historically, they were reserved for young age, high school, college-aged athletes with acute tears, and the devices that we use to repair them are constantly improving. Now, the past decade or so, they've been done almost exclusively arthroscopically, meaning you don't have to make a big excision. You have tools that can put little anchors into the meniscal tissue, with stitches that are attached that can sew the meniscus fragment back into place. And this, there are various different devices that do this, but this is typically the idea behind the majority of the techniques. And the indications are expanding. We tend to keep increasing our indications for repairs. It's no longer reserved just for that young age group now, with the better techniques for repair and the addition of the biologics, using blood clots and things. You can get meniscal tears in an older age group to potentially heal, and preserving the meniscus is one of the key factors in preventing arthritis. Moving on to ACL injuries, the other big injury in the knee in every age group, the dreaded tear of the ACL. So the mean age historically of ACL tear, most of which need surgery, is 29 years old. That demographic is changing. This is data from a few years ago showing that older and older patients are getting ACL tears and other sports injuries because of the increased demands of an active lifestyle and people remaining healthy and living healthy for longer. And that has continued to increase dramatically. It's also increased in the other direction. You see younger and younger kids getting ACL injuries because of the intensity of sports in school and clubs, and doing the same sport year round, and being more prone to these types of injuries as well. ACL grafts have evolved a bit over the years. This is an example of a allograft or a bone tendon bone graft, which can also be an autograft, meaning taken from the body. Allografts mean it comes from a tissue bank, a cadaver. These can be harvested and preserved and used as an ACL graft, which is great because it means a little less surgery. You're not taking or harvesting tissue from somewhere else in the knee, smaller incisions, quicker recovery. The problem is, and what has been shown actually relatively recently, is that the younger patients do better using their own tissues. So age 30 or 25 and below, basically, we typically use autograft. Age 35 and above, we tend to go back to allograft because the differences aren't really, there isn't a difference between the outcomes of using an allograft or an autograft. Between the age of 25 and 35, I kind of make it dealer's choice and have the discussion and base it a little bit on a case-by-case basis. Autografts, historically, one that I prefer to use the most is the hamstring. It's a soft tissue graft that you take two out of the four hamstrings out of the back of the thigh through about the same size incision as you use to reconstruct the ACL. And it's a very strong graft and can also be used in younger ages where you have open growth plates because you're not putting a bone plug across the growth plate, which can cause problems with growth arrest and other things. Patella tendon has historically been the gold standard, something where you take a piece of the bone out of the kneecap, attached to the patella tendon, and then you take another piece of bone out the other end at the tibia. which gives you the graft that's pictured. And that's the advantage of that is you get bone-to-bone healing. It's a very strong graft. Fixation has been tested to be one of the strongest. And there are downsides, though. You're taking a big chunk of bone out of the tibia, and the patella can lead to pain, anterior knee pain, which has been perhaps slightly increased in patients using patella tendon autograft, or even arthritis of the kneecap, or in dire circumstances of fracture of the patella. Quad tendon has become a popular graft as well. You're taking a piece of the tendon above the kneecap, still taking a piece of bone from the kneecap, but the other end is soft tissue. So it's kind of a compromise, and it's become more popular actually in recent years. Fixation of the graft has evolved. We used to use metal screws, which you could see on an x-ray, and would bite into the bone and hold the graft or soft tissue in place. Then we moved on to plastic screws, which were a little bit better for the tunnels that you were drilling in the bone, would have a little bit less reaction and create less osteolysis or widening of the tunnel, which could lead to graft failure over time. And then the latest and greatest is the bioabsorbable screw. And these are made of materials, calcium-based, that can dissolve over time and actually get replaced by bone of the patient's bone. So the tunnels kind of disappear. So that's what I use almost exclusively now. And then the soft tissue fixations are the picture on the bottom row. It's called a pro cinch, which is kind of like a tight rope where you can loop the graft, which you can see just at the bottom of the picture there, through polyester sutures, and then drill a very small hole through the lateral cortex where you can flip that button, and then tension the graft that way. So again, autograft can be harvested either from the patella tendon. I already described the patella tendon bone-to-bone allograft, and then this is an illustration of the hamstring harvesting, where through a smaller incision, right where you're also placing the tunnel for the tibial side of the reconstruction of the ACL, you can harvest the gracilis and the semitendinous, two of the hamstrings on the inside of your thigh. And the advantage of that is smaller incisions. All soft tissue has its advantages, and the hamstrings regenerate over time. Over the course of about the time it takes to rehab from an ACL reconstruction, about 6 months, the hamstring regrows, and you can actually go back and harvest it again a year or two later, although that's not recommended. So the deficits that you'd think would arise from missing half of your hamstrings in the back of your leg are mitigated. So moving on to OCDs, or osteochondral defects. These are defects in an otherwise healthy knee. So we're not talking about an arthritic knee at this point, but where you have a little defect in the cartilage, like a pothole in the road, where the rest of the surrounding cartilage is normal. So doesn't need a knee replacement, very hard to get cartilage to regrow. One of the things we've been working to regenerate, Harbor Master, that can't be good. Ways of getting that cartilage to regrow have been some of the holy grail of orthopedics. And one of the techniques that I use is called a microfracture, which means removing the damaged part of using awls, you can actually poke little holes in the subchondral bone. So it starts with removing the damaged cartilage. First, you find these often incidentally when you're in the scoping a knee for some other reason. You find this pothole in an otherwise healthy knee. So it involves cleaning away the damaged portion of the cartilage, creating a stable rim or a bed for the new cartilage, and removing the subchondral layer, which is this calcified layer that sits over the chondral bone, which separates the bone marrow from the joint, that white line just underneath the joint surface. And then using these awls, you can poke a bunch of little access points through into the subchondral bone, the marrow, essentially. And what that does is allow a blood clot to form, but it's a blood clot formed of bone marrow cells, which are stem cells. So it's one of the original stem cell therapies. And then this clot can differentiate over time and form cartilage and refill that gap. It's not quite as good as real cartilage. It's still scar cartilage, but it's better than having a pothole in the middle of your knee. This is more for historical purposes. This was using cartilage from other parts of the knee, growing it in a lab, and then reimplanting it into that same pothole. And you're taking a little piece of periosteum off the upper part of the tibia to create a patch. So this is a multi-stage procedure. You have to go in and harvest the cartilage and then send it to the lab 6 weeks later, come back and perform this relatively delicate, elaborate procedure. So that's largely been replaced by scaffolds that are made in the lab that come either with the patient's own cells, so autograft, or using live cartilage cells from other sources. You can also use dowels, basically taking chunks of cartilage from parts of the knee where they don't see as much force or are not as weight-bearing, like the lateral ridge of the trochlea on the femur. You can see where you're harvesting some cartilage where the patella just barely articulates, so it's spare cartilage, essentially. It's also where you harvest the cartilage to send to the lab and fill in the defect on the knee using these little dowels. Also something that we don't use as much, and then there's filling in big defects. This is more using an allograft, so a piece of a cadaver knee that has to be matched and carefully measured and everything to use to replace a big chunk of the missing cartilage. So these are for bigger defects. Now there's various different products available on the market. This is juvenile live cartilage and bone fragments that can be used as a patch mixed with fibrin glue, create a little clot essentially that can be placed into the defect, single stage procedure, similar results to these other historic procedures that we've used. Another mention for patellofemoral pain. So irritation of the kneecap because of either maltracking of the kneecap or arthritis of the kneecap, history of previous dislocations, often leading to an imbalance between the quad and the hamstrings, and a variety of other disorders can lead to chronic knee pain that is felt in the front of the knee, worse with going up and down stairs or weighting the knee joint in athletic activities. So this is a procedure where you can actually realign the extensor mechanism of the knee by moving it medially so that the pull of the patella is no longer making an angle around the knee joint and can realign it. It can also be moved anteriorly, creating less force behind the kneecap. So this is something I used to do a lot more of. It's a big procedure. You're basically cutting a large piece of the proximal tibia and shifting a big wedge of bone over and then holding it together in with screws. So it takes a long time to heal. This is not as common as it used to be for a variety of reasons. One is better conservative measurements for treating it, physical therapy, and then specifically for arthritis of the kneecap and the advent of Makoplasty and the robotics and the ability to put these partial joint replacements in with much better precision allows us to bypass the fulcrum or a lot of the osteotomies, replace parts of the knee that are damaged when it's not a complete arthritic picture where it requires a total knee replacement, and joint and parts of the knee that can be replaced are the medial side, the lateral side, or the patellofemoral joint. So historically, early stage mild disease came to me, had an arthroscopy, fixed meniscal tears, dealt with injections and physical therapy, no problem, things would improve. Late stage severe disease, the treatment is a knee replacement that has been historically very successful. So The problem up until the advent of these better technologies for partial knee replacements was that mid-stage, the moderate disease with pretty severe arthritis but localized to only one part of the knee joint, leading to increased pain, reduced mobility, changes in lifestyle and sports activities, and not a good solution. The only options were living with it and having semi-effective conservative measures or having a total knee replacement prematurely. So the robotics has really revolutionized my practice and what I can offer for these middle-aged athletes who want to stay in the game, don't want a knee replacement, but the soft tissue procedures that we can offer just aren't going to fix the problem. So the partial knee replacements filling in that middle category, which had been a void for some time. And again, you can pick and sort of fine tune or customize the type of knee replacement that you would use for these patients. And you can even do 2 out of the 3 compartments, medial and patellofemoral. Someday we may be just replacing each compartment as it's needed. But the total knee replacement still remains a standard. We've had to fine tune our indications to some degree for the partial knee replacement because these days the goal is to have it be your last procedure. You don't have to have something else done to your knee again, like a revision to a total knee. That's something we'd want to avoid. So in conclusion, as the population remains active for longer, the rates of orthopedic injuries continue to rise, particularly in the older and the younger age groups. Conservative measures are still primary treatment options, and 90% of the people I see don't end up going to the operating room. And when it does come to surgery, our techniques continue to evolve, becoming less invasive and more precise. Thank you.